Good morning, sirs, ma'ams. I'm P2LT Redson Iro L. Valencia Medical Corps, second year resident of the Department of Orthopedics and Traumatology. For today, we will be talking on how we evaluate bone lesions on plain radiographs. Plain radiographs are the most important investigation for bone tumors. Plain radiograph is a necessary and cost-effective investigation for patients who present with a bony mass without significant pain or patients with painful bone lesions or even patients with pathologic fractures. The radiographic appearance of the lesion will help the clinician develop an initial differential diagnostic list and determine further clinical and radiographic investigations. Analysis of the plain radiographic abnormalities, therefore, is a critical part of the workup of the musculoskeletal oncology patient. And here are the 7 questions we have to answer. Once these questions have been answered in association with the clinical assessment of the patient, the biologic activity of the lesion can be classified as benign, latent, active, or aggressive, or malignant. If malignant, lesion can be classified as probably mesenchymal, myeloproliferative, or metastatic, and if mesenchymal, as high-grade or low-grade. The first question to answer is where is the lesion? It is important because together with the age, it may give us clues on what we're dealing with. And here are some generalizations. Symptomatic metastatic tumors are usually found proximal to the knees and elbows. In contrast, if they are found distal to it, they are usually result of metastatic lung cancer, renal cell cancer, and melanoma. Second, phalanges are a common site for enchondromas, which may be quite active and destructive in the hand but are rarely malignant. Next, tibia is a common site for two rare tumors, osteofibrous dysplasia and adamantinoma. Adamantinoma is rarely found, but when it is, the lesion is in the tibia and virtually never elsewhere. Next, aggressive and malignant primary bone tumors most frequently occur in the regions of greatest longitudinal growth. These sites include the metaphyses of the distal femur, proximal tibia, proximal femur, and proximal humerus. Chordosarcoma is more frequently found in the proximal skeleton, including pelvis, scapula, proximal humerus, and femur, than in the distal extremities. Chordoma is most commonly found in the sacrum and at the base of the skull. Much less frequently, chordoma arises in the remainder of the spinal column. The anterior spine is frequently involved in the metastatic disease. Primary tumors most commonly found in the spine include giant cell tumor and aneurysmal bone cysts in the anterior spine, while osteoidostroma and osteoblastoma from the posterior elements of the spine. After assessing the bone that is involved, next determine the portion of the bone involved. The skeletal anatomic regions that may be affected bone tumors are defined as follows. Periarticular, in which changes are present on both sides of the joint or present in the soft tissue bursae surrounding the joints. These changes are evident in pigmented bilionodular synovitis and synovial chondrometaplasia. It's also important to note that infectious, inflammatory, and metabolic joint disease such as gout may also present with periarticular erosions of bones. Lytic lesions that extend across the joints to involve the adjacent bones suggest vascular tumor, such as disappearing bone disease, Yorgorham's disease, or angiosarcoma of the bone. Epiphyseal lesions in adults that may extend across the growth plate scar but are clearly centered in the epiphyses is typical of a chondroblastoma. Epiphyseal and metaphyseal is a classic location for locally aggressive tumors such as your giant cell tumor. Enchondroma unicameral bone cyst that grow away from the feces versus your Brodys abscess that can extend across your feces is typically located in metaphyseal area. Your metaphyses is also the most common site for primary mesenchymal malignancy such as your osteosarcoma and your chondrosarcoma. While your diaphyses is also a common site for malignancy such as Ewing sarcoma and metastasis, and others like eosinophilic granuloma and osteodystroma. We also have your parastyle or cortical, and this location describes lesions that are attached to the surface of the bone. Examples include your osteochondroma or your parastyle osteosarcoma. Other lesions may grow directly within the cortex, such as your osteodystroma or periosteal chondroma. It is often necessary to obtain cross-sectional imaging to delineate the relationship of the parastyle lesion or cortical lesion to the surface of the bone. CT and MRI are valuable for analysis of the relationship between the lesions and underlying cortex. MRI is superior for determining if the lesion has extended within the marrow cavity. For soft tissues, some lesions with calcified or ossified matrix may be present and well visualized on conventional radiographs. Examples include your myositis ossificans and soft tissue sarcoma with ossification that might include malignant fibrous histiocytoma and synovial sarcoma. Next one is the lesion central or eccentric in location. Central lesions include your enchondroma or your fibrous dysplasia. On the other hand, eccentric in location usually involves your non-ossifying and chondromyxoid fibroma. In general, the larger the lesions, the more likely it is to be aggressive or malignant. Conversely, smaller lesions such as osteodystroma are usually benign. However, this is not universally true because benign lesions such as fibrous dysplasia may be quite large. Some benign indicators include size less than 5 cm, movable when you palpate it because it is only superficial or above the fascia, or has homogeneous matrix. For osteochondroma, a cartilaginous cup of more than 2 cm must be evaluated for the uh, probability of osteosarcoma. The size of the lesion is also one of the factors in Merrell scoring system for metastatic bone disease, in which the more cortex involved, the higher the score. For the next question, bone tumors have a limited number of potential effects to the bone, and the most common one is to produce lysis. The pattern of lysis provides major clues as to whether the lesion is latent, active, aggressive, or malignant. The most favorable pattern of bone lysis is that of geographic lytic lesion, in which it is easy to determine exactly where the bone lysis begins and ends. So there is a narrow zone of transition. This change is typical of unicameral bone cyst, chondromyxoid fibroma, and your non-ossifying fibroma. A far more worrisome change is the appearance of a moth-eaten or permeative margin. In this situation, there is a wide zone of transition, meaning it is difficult to determine where the lesion begins and ends. The lytic change seems to be percolate through the trabeculae with little host tissue response. These changes are typical of malignant lesions, including your mesenchymal tumors, lymphoma, metastatic, and Ewing sarcoma. The next question to ask is, what is the bone doing in response? Often, the bone responds by making a new bone, which can be seen either in medullary, cortex, or periosteum. In marginal sclerosis, it is characterized by a dense layer of lamellar bone forming in the medullary canal around the lesion, and it is typical of the response to benign latent, active, and even slow-growing aggressive lesions. This pattern may be observed with non-ossifying fibroma or fibrous cortical defect, chondromyxoid fibroma, or in some cases of fibrous dysplasia. Bone may sometimes respond to a very slowly growing focus with cortical thickening, the best example of which is your cortical osteodystroma. And this reactive walling off process suggests a non-aggressive benign lesions. However, in some cases of slowly growing aggressive or low-grade malignant tumors, periosteal new bone is formed in response to endosteal erosion caused by the tumor. The combination of the endosteal erosion and periosteal new bone apposition results in an appearance best characterized as your endosteal expansion, in which both the medullary canal and the outer cortex of the bone increase in diameter. And this pattern is typical of your lower grade chondrosarcoma. Periosteal neocortical response is observed with rapidly expanding benign aggressive lesions such as your giant cell tumor or aneurysmal bone cyst. There is destruction of the overlying cortex and rapid expansion of the tumor. However, as this benign aggressive lesion expands, the periosteum remains intact over the surface of the lesion and a thin neocortex is formed. We may also observe a poorly organized periosteal new bone in response to rapid tumor growth. It is typically seen in osteosarcoma or Ewing sarcoma. It is variously observed as a Codman's triangle, starburst appearance, or laminated onion skinning, and it produces radiographic evidence that the tumor growth has outstripped the bone's potential for responding to the lesion. There is often an associated soft tissue mass on top of the intact cortex with surrounding periosteal new bone. For enchondroma and chondrosarcoma, they are frequently lytic areas interspersed between the calcified matrix. In cases of osteoblastoma, the osteoid matrix is mainly due to the host bone response to the lesion rather than the true tumor bone formation. While osteosarcoma often demonstrates bone formation within the intraosseous lesion or in the soft tissue mass that is usually associated with the tumor. Fibrous dysplasia produces matrix through the small trabeculae of woven bone scattered through the fibrous stroma. In addition to the matrix formation observed in the chondroid and bone-forming primary tumors, it should be remembered that metastatic disease, including breast and prostate, can induce a marked sclerotic response in bone. The second to the last question is if the cortex is eroded. Cortical erosion is a hallmark of the active, aggressive, or malignant tumor, and the pattern of cortical erosion may be highly correlated with the histology of the lesions. In general, lower-grade tumors will produce endosteal erosions with orderly periosteal response, leading to your endosteal expansion, while higher-grade tumors will erode through the endosteal surface without an adequate response from the bone, resulting in a significant risk of fracture. For the last question, the presence of a soft tissue mass usually indicates that the lesion has extended through the cortex, which is an indicator of an aggressive or malignant lesion. Aggressive lesions tend to have smaller, more contained soft tissue masses. Generally, the soft tissue mass is contained by the development of this neocortex. Soft tissue masses are certainly found with aggressive tumors, particularly in the regions of metaphyseal bone where the periosteum is deficient. Other feature that discriminates between the soft tissue mass in aggressive and malignant tumors is the relationship of the mass to the cortex. Aggressive tumors almost always develop a soft tissue component by destroying the cortex and expanding into the surrounding tissues. Malignant tumors may extend by this route, or alternatively, they may grow directly through the Haversian canal system of the cortex, leaving the cortex structurally intact. The hallmark of a soft tissue mass associated with a bone sarcoma is that it lies on top of the intact cortex with sarcoma present inside and outside the cortex. Presence of malignant matrix in the soft tissue is almost always a sign of mesenchymal malignancy. So in summary, plain radiographs is essential in the MSK Oncology armamentarium, especially in our country in far-flung areas in which plain radiography is the only accessible imaging modality. Hence, it's important for us to know these 7 X-ray questions by heart, because answering these questions can help us develop an initial differential diagnostic list and determine further clinical and radiographic investigations. Thank you.